Now I'd like to discuss how some of the history from the women's health movement can provide us with a framework for understanding and advocating for the healthcare needs of the trans community. Several of the issues confronted by the feminist women's health movement, such as creating a more compassionate and respectful healthcare experience, challenging hierarchy and paternalism in healthcare, all of these issues that Laura talked about in the early history of the women's health movement, and also working to break down the model of medical professionals as gatekeepers to care, are concerns that are currently being addressed by transgender health advocates. I'd like to focus on what I see as a striking similarity between women's experiences trying to access abortion care in the US prior to Roe versus Wade, and trans people's current experiences trying to access hormone therapy for gender transition. As many will recall, in the pre-Roe days, women desperate to obtain abortions resorted to clandestine providers who were often unsafe and unethical. Many of the oral histories from this period document women's negative experiences of exploitation, humiliation, and even abuse at the hands of disreputable back alley providers looking to profit off of women's desperation. Women who wanted to try to obtain an abortion through the legitimate medical establishment had the unenviable option of trying to gain permission from a so-called therapeutic abortion committee at a hospital. In her book, Abortion Wars, Rikki Solinger provides an account of how one such committee worked at a hospital here in New York City, and I'll quote from her work. The director of the Obstetrical and Gynecological Service is chairman of the Permanent Abortion Committee. The other members are chief or senior attending from the departments of medicine, surgery, neuropsychiatry, and pediatrics. No case is considered unless the staff OBGYN desiring to carry out the procedure presents affirmative letters from 2 consultants in the medical field involved. 5 copies of each letter must be filed at least 48 hours in advance of the meeting. The case is then carefully discussed, and if any member of the 5 on the committee opposes therapeutic interruption of the pregnancy, the procedure is disallowed. Solinger remarks, the fact is, many women whose unwanted pregnancies were vetted by abortion boards in the 1950s and 60s say that these experiences were among the worst of their lives. Many could not bring themselves to submit to such a process and went off on their own in search of an abortionist. Other women did apply to the board, were denied an abortion, but emerged with their determination undiminished. These women, too, often went to the so-called back alleys. The purpose of these committees was to determine if a woman had a medical or psychological contraindication to pregnancy that would make the abortion permissible. Again, I'll quote from Solinger. To a significant extent, psychiatrists help by providing myriad esoteric ways of selecting who should and who should not be permitted an abortion. Most of these ways were based on providing a clinical answer to the question, is this woman psychologically fit to be a mother? Answers in the negative, which were those that gave women actual permission to have the abortion, at the same time defined the petitioner as unfit, unwomanly, and to some degree depraved. The means and the ends here were both degrading to women seeking to control their fertility, end quote. As history has shown us, this model in which medical and mental health professionals serve as gatekeepers in determining who can have access to safe medical care drove determined individuals to seek what they needed outside of the medical establishment, putting themselves in harm's way. In a similar way, I would argue, the substantial barriers that have been created for trans people trying to access hormone therapy have contributed to a public health crisis in the community, where many are forced to get their hormones from the black market and then self-administer the medications without medical monitoring for proper dosing and side effects. Even more concerning, many trans people self-administering hormones are injecting them, oftentimes sharing needles. The Sylvia Rivera Law Project, a transgender rights advocacy group here in New York City, conducted focus groups with low-income transgender individuals to discuss barriers to health care. In a response to a question about the health risks of self-administered hormones, one participant said, and I quote, "The risks? Death. You don't know what you're taking if it's not prescribed by the medical doctor. I had a friend who, through taking street hormones that way, well, she had to have her gallbladder removed. You see, when they're selling you hormones, they don't just sell you pills. You also have the estrogen that they sell you in the bottle and the syringe needles. A lot of the time, you don't know what you're getting. They could be selling you dirty, unpackaged syringe needles along with the hormone to insert in your body. You expose yourself to the risk of getting hepatitis, HIV, all sorts of other illnesses. This is our lives on the line, and it's really important for people to know that, end quote. So what are some of the barriers to accessing gender transition-related hormone therapy? Well, first, various iterations of the actual professional standards of care for transgender health are themselves barriers, and they place various levels of hurdles in the way depending on the version of the protocols that you look at. But early versions of what is now called the World Professional Association for Transgender Health, or WPATH, standards of care, require that individuals complete a documented real-life experience in their identified gender of 3 months to 1 year, depending on the version of the standards that you look at, or a period of psychotherapy of a duration specified by the mental health professional, and that's important, after the initial evaluation. Usually the minimum period of psychotherapy would be 3 months, but it could be longer. These standards are problematic for multiple reasons. First is it's extremely difficult for many trans people to pass fully as a member of their identified gender without the aid of hormone therapy. Given the pervasive societal discrimination and violence aimed at openly trans individuals, asking them to go about their daily lives without the assistance of hormones to help them pass as their identified gender can actually be outright dangerous for them. Also, the mental health evaluation and psychotherapy requirement can prove to be insurmountable barriers to many. First, it can be difficult to find a mental health provider who is appropriately trained and experienced in working with trans individuals. Also, the cost of extended psychotherapy can be prohibitive, especially when many trans people are poor, uninsured, or their health insurance specifically excludes coverage for transition-related care. And this is actually quite common. Most insurance companies exclude any transgender-related medical or mental health care. Finally, the very requirement that a trans person be evaluated by a mental health professional prior to initiating hormones is predicated on the assumption that trans people suffer from gender dysphoria or gender identity disorder, which is a mental health diagnosis that's extremely controversial within the community. Many find the diagnosis to be unnecessarily pathologizing and a suggestion that being transgender in and of itself is a mental illness. However, within the existing WPATH standards of care, the diagnosis itself is still a requirement for access to hormones. This echoes women's experiences with therapeutic abortion committees pre-Roe, where a stigmatizing mental health diagnosis was often the trade-off for accessing an abortion through the legitimate medical establishments. The requirements for access to hormone therapy in the most recent versions of the standards of care have relaxed a bit in response to feedback from community advocates, but they are still far from ideal. They still require that a psychosocial assessment be conducted by a mental health professional and that this mental health professional provide a referral letter to the medical provider who will prescribe hormones. The persistence of the referral letter requirement perpetuates the gatekeeper model wherein mental health professionals determine whether or not an individual will have access to medical care.